welcome back to another insightful episode of MedSynapse podcast series. Today, we are diving into a condition that can be as frustrating for clinicians as it is for patients, which is chronic urticaria. From elusive triggers to stubborn symptoms, it's a dermatological puzzle that calls for both precision and patience. And joining us to unpack the clinical approach to managing this condition is Dr. Ranchit Narang, a qualified dermatologist holding an MBBS, MD, and DNB in dermatology. He currently serves as an associate consultant dermatologist and is known for his evidence based approach to treating complex skin conditions with empathy and expertise. So, Dr. Ranchit, welcome to the show, and it is so great to have you with us today.
Thank you, Ms. Setri, and it will be highly obliged that I'm a part of this talk. Yeah,
So I'm
sure.
also excited to have this discussion with you, Doctor. So let's
Yeah,
just begin with the basics for our audience that spans, both specialists as well as generalists. So what exactly is urticaria, and are there particular subtypes or phenotypes that tend to be more refractory to standard antihistamines?
yes. First of all, we have to understand about the urticaria. Urticaria is just like a chronic normality disorder that just happens secondary due to release of the histamine, like from the mast cell, from the basophils. And as a clinical feature, it can present as a transient or evanescent erythematous patches all over the body. That is usually blanchable, and then they just last long for 24 to 48 hours. So, firstly, we have to differentiate the urticaria into two parts, that is acute and the chronic part. And after that, we have to just rule out the possible closable factor for the urticaria. Like there are few factors that usually triggers the acute urticaria, and there are different factors that usually triggers the chronic urticaria. For the acute urticaria, the first factor is like infection. If the patient usually present before the 6 weeks, like patient usually getting the urticaria from last 6 weeks, we label it as an acute one. And so to label it as a chronic urticaria, patient usually present with the complaint of 5 to more than 6 weeks. And on the basis of that, we calculate the US score every week. There are various causes for the chronic urticaria. The first of all causes is like a autoimmune cause. Like autoimmune, I mean to say, if there's somebody usually having a history of any thyroid, diabetes, or the pernicious anemia, the patient can be lined up into the chronic urticaria. So there are two type of chronic urticaria. One is the chronic idiopathic urticaria or the chronic spontaneous urticaria. The next one is like a chronic autoimmune urticaria. And another one is a chronic urticaria, usually induced by the physical or the inducible stimuli. The first stimuli can be like emotional stress. It can be vibratory induced. It can be exercise induced. It can be food induced. Even it can be sunlight induced. Even it can be cold induced. But first of all, before like ruling out it as a chronic urticaria, patient usually suffer a lot from this problem. Sometimes what happens if the patient usually present with no history or no comorbidities of the thyroid or the diabetes, so we can just check it for the thyroid levels like T3, T4, and the TSH. Most of the time, the thyroid levels usually are in the suboptimal limits. Then we have to check for the antibodies to the thyroid. Because what happened in the case of autoimmune urticaria, the antibodies to the thyroid usually get stuck to the FcR1 receptor, which are usually present over the serum IgE. That usually causes the mast cell to release the histamine that usually triggers the urticaria. So, urticaria response wise, if we talk about the treatment wise, chronic idiopathic urticaria is resistant to the antihistaminic most of the time. So, like the standard dose is like one tablet per day. If you're suppose giving any form of second generation antihistaminic, like bilastine, loratadine, fexofenadine, initial protocol is to updosing of the like antihistaminic if the patient is not getting any relief. And suppose if the patient is not getting relief from the like antihistaminic, we have to updose up to the 4 times. After that, we can just go to the second line or the third line drug.
Yeah, I think, Doctor, that actually brings clarity to the, what do I call, heterogeneity of this condition. So,
Yes.
moving a step ahead, beyond antihistamines, what pharmacological options have proven most effective in your practice?
Actually, there is a way to give the anti-allergic. If we are just going to follow the guidelines that is usually recommended by the EAPI guidelines or the European guidelines, and some of these are the Indian guidelines also.
Mm.
So, firstly, we have to start one tablet, like anti-allergic. If we're talking about the antihistaminic part, if the patient is not getting relief, then we updose it to up to the 4 times. If the patient is not getting relief from the antihistaminic, like suppose some usually practitioners have a habit of giving the non-sedating one depending upon the occupation of the patient. If the patient is like pilot or driver by occupation, we recommend the patient to just one like a non-sedating one. And if the patient is like normally a doctor by profession or businessman by profession, we prefer to give the sedating antihistaminic in the night time and non-sedating in the morning time. And we have to observe at least for 2 weeks. If the patient is not getting any relief up to 2 weeks or 4 weeks, then we have to think about the second line therapy. Second line therapy is like a monoclonal injection, that is omalizumab, which is like a monoclonal humanized antibodies. And the third line therapy is a cyclosporin. And there are also few off-label therapies which we will given in the urticaria, depending upon the response and depending upon the severity of the urticaria, because not every patient usually can afford the biological injection for the urticaria.
I think that layered approach is makes a lot of sense, and especially with a condition that doesn't always follow the rule book, I would say. So, doctor, can you share a case that stands out to you? Maybe one patient where the patient failed conventional therapy but responded well to second line or off-label treatments, and what made difference in your clinical approach?
Most of the time, if the patient present with the acute urticaria, that part usually get resolved within a 2 weeks or 3 weeks maximum. If the patient or if the doctor is able to just identify the triggering factor. Suppose if the patient is going to land up into chronic idiopathic or chronic autoimmune urticaria, then definitely the patient usually suffers a lot from the daily hives or the quality of life usually get impaired. In that case, we have to think about the second line or the third line therapy. Like some of the patients are there usually which not get any relief either from the antihistaminic, either from the immunosuppressant, either from the omalizumab. All these things usually happens due to receptor saturation. So in that case, we have to take either help of any other drug which are usually off-label, or either we can just try something which are not mentioned in the books or not usually mentioned somewhere just according to the like experienced one. So I have tried like autologous serum skin test in few of my patients who are not getting any relief from the biological injections, cyclosporin or the antihistaminic. Because what happened, if the patient present with the chronic idiopathic urticaria, most of the time the cause is autoimmune. So we have to hit that patient either with something that usually capture the autoimmune part. So we did ASST. ASST is a process in which we withdraw the blood and separate the serum from the plasma. And after that, we can just inject it in the intramuscular route after doing a ASST sensitivity test. And we have to do that session once a week for 4 weeks. After that, once in a month for at least 3 to 4 months. Like I'm doing in my practice, most of the patients are getting relief from that part only. But nowadays, the practitioner do not follow this ASST because this is a long way back. This is usually going to use like in the 2010, 2011. But we have to sometimes follow the older approach also in the refractory patient or the recalcitrant patient.
So it would definitely depend on how the patient is also reacting, right, or
Yes.
what the patient's condition is. So, Doctor, now looking ahead, what is your opinion on the newer targeted therapies in the pipeline for urticaria? And do you think we are approaching on an era of true precision dermatology for this condition, especially?
To be very frank, right now there are like different biological drugs which are usually going to be under phase trial for the urticaria. I have not any like personal experience with that drug. Like interleukin 4 inhibitor, like dupilumab, is usually in the phase one or phase two trial, and like omalizumab analog, which is ligelizumab, is also under trial. And another drug, which is KIT mutation drug, and Bruton kinase inhibitor drugs are also under trial. So it is difficult to say like what type of usually patient usually get benefited from
Correct.
like new drugs till the time the various study or the various literature or head to head trials or the randomized control trials if they are going on. After that we can just comment upon this part.
Yeah, I think the shift is also necessary for, these conditions especially. So, Dr. Now to wrap up, you interact with both dermatologists and general practitioners. So, where do you see the biggest knowledge or practice gap in managing urticaria? I think this would be a
Uh,
very interesting question.
Most of the time, the bigger gap is usually in the like implementation of the guidelines, usually recommendation by the good
Hmm.
generals or good authorities like ERP guidelines and the Indian guidelines. Most of the time, the general practitioner are not going to follow that part. They just either give the systemic steroids like for a longer duration of the time, or either they just prescribe the non-sedating antihistaminic, being hesitation in updosing that part. I think we should follow that part, or like to be get up to knowledge for the urticaria part in order to treat the patient or improve the quality of the life. And the second gap is like, first of all, the practitioner should be able to differentiate between two things. The first one is like acute urticaria or the autoallergic urticaria or autoimmune urticaria, so that we can treat that part in a different way pattern. This is not only just to get some good knowledge about the urticaria, but to like just to build a good like a rapport, or like just to build a good relation with the patient also for his or her care now.
Yeah, definitely. I think that's a practical takeaway, Doctor, for all our listeners.
Definitely.
So, Doctor, thank you so much for sharing your
Thank
insights
you.
with us today. And to our listeners, if you found this episode helpful, do not forget to follow us for more such expert led discussions. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay informed and stay inspired.